part 2. And in this, we shall be discussing about staging, diagnostic workup, treatment, management, therapy, and survival. Coming to the staging, which is TNM staging. So, T0 is no evidence of tumor, TIS is carcinoma and C2. T1 is tumor which is less than or equal to 3 centimeter. Now, T1 is further subdivided into T1A, T1B, and T1C. T1A, which is less than 1 centimeter, T1B, 1 to 2 centimeter, and T1C, greater than 2 but less than 3 centimeter. Coming to T2, tumor which is greater than 3 but less than or equal to 5 centimeter. And if it involves any of the main bronchus, but there should not be an involvement of carina. If it invades visceral pleura, and if there is an associated atelectasis or obstructive pneumonitis. T2 is further subdivided into T2A and T2B. So T2A is greater than 3 but less than 4 or equal to 4, and T2B is greater than 4 but less than or equal to 5 centimeter. T3 is tumor greater than 5 centimeter but less than or equal to 7 centimeter, or if it directly invades 3Ps, which you have to remember, that is parietal pleura, if it invades phrenic nerve, or if there is involvement of pericardial pericardium. And if there is a separate tumor nodule in a same lobe as a primary. T4 is greater than tumor 7 centimeter, or if it involves major structures like diaphragm, mediastinal, heart, great vessels, carina, and if there is a tumor separate nodule in ipsilateral lobe different from that of primary, even if there is in a thus ipsilateral lung. End staging, N0 no regional lymph node, N1 if there is an metastasis into ipsilateral peribronchial or ipsilateral hilar or intrapulmonary region, including involvement by direct extension. N2 if there is an involvement in the metastasis in ipsilateral mediastinal or subcarinal lymph nodes. N3 to contralateral like mediastinal, contralateral hilar, supraclav, scalene. M category M0 nomads. M1 which is further subdivided into A, B and C. A separate tumor nodule and contralateral lobe, or if there is pleural or pericardial nodules or effusion. M1B single extrathoracic metastasis in single organ, and M1C is multiple extrathoracic metastasis. So these all are diagrammatic deception. Coming to the small cell carcinoma staging, so it is divided into limited or extensive stage. Limited when the tumor is involving only a primary site associated involvement, but if an extensive in which there is extensive tumor involvement to the multiple sites like brain, liver, bone, or any other site of a metastasis or to the contralateral lobe. So how we proceed if the patient presents to us with a suspected CLR? History and physical examination, of course, which is most important. Then if the patient gives us the weight loss history of greater than 5% from baseline, it has a direct prognostic implication for survival in lung carcinoma. Lab, CBC, RFT, chest X-ray, of course, the primary investigation, bronchoscopy, which helps us even in the biopsy of the tissue, endobronchial ultrasound, which uses in both diagnostic and staging, CCT chest and upper abdomen, PET-CT standard in staging workup, and CT-guided biopsy for the diagnosis. So in the CT, in the lung window, we can see a solitary nodule present on left lower lobe. And in the PET-CT also we can see the destruction. Coming to the management, so management of lung carcinoma differs histological wise, like for non-small cell and small cell. First, we will see about non-small cell. It is also further subdivided based on stage. So if we see into the stage 4 and 2, if it is operable, lobectomy is preferred, which is followed by adjuvant chemotherapy. If it is stage 1 and 2 inoperable, if it is T1, T2, and 0, then definitive stereotactic body radiotherapy. T3 and 0, definitive chemoradiotherapy. Stage 3A, if it is operable or marginally operable, then chemoradiotherapy. And if we should restage, followed by chemoradiotherapy. And if no progression, surgery. Stage 3A, inoperable, then chemoradiotherapy. 3B, the standard of care is chemoradiotherapy. Stage 4, consolidation chemo after chemoradiotherapy, or palliative treatment or best supportive care based on patient's presentation and general condition. There are various targeted therapies which are also been available in CLR. So first we'll see EGFR mutation. So if the mutation is discovered prior to first line systemic therapy, so osimertinib is preferred, and others include erlotinib, afatinib, gefitinib, or dacomatinib. And if the mutation is discovered during first line of systemic therapy, then we should complete planned systemic therapy followed by the above drugs like osimertinib or erlotinib, afatinib, and gefitinib. If the patient have ALS mutation and if it is discovered prior to the giving any systemic therapy, we should give elkitinib, brigatinib, loratinib, seditinib, or crizotinib. If it is discovered during the first line of systemic, then we should complete systemic therapy followed by above drugs. If there is ROS1 mutation seen prior to the systemic therapy, we should offer patient with entricitinib, crizotinib, or seditinib. And during the first line, then we should complete the planned therapy followed by above drugs. Chemotherapy regimen in non-small cell lung carcinoma, which is preferred in adenocarcinoma, is pemetrexed and cisplatin, and in squamous cell, we generally prefer paclitaxel cisplatin or gemcitabine and cisplatin. And in small cell carcinoma, the chemotherapy regimen given is cisplatin plus etoposide. Coming to the management of small cell carcinoma, based on staging, if it is limited, then chemoradiotherapy. Concurrent chemoradiotherapy means cisplatin plus etoposide and early radiotherapy. And if there is complete or near complete response, then we should go ahead with prophylactic cranial radiotherapy. If it is an extensive disease, then we should give combination chemotherapy, which includes cisplatin plus etoposide. Based on the patient's symptoms, we can offer the patient with palliative radiotherapy. The median overall survival in limited stage small cell carcinoma is around 20 months, and 5-year overall survival is 20 to 26%. In extensive disease, the median overall survival is around 12 months, and 5-year OS is less than 5 to 10%. If we see overall survival in non-small cell carcinomas, so stage wise, in stage 1A it is around 5 to 10 years, 1B 3 to 7 years, stage 2A is around 3 years, and 2B is 1.5 to 3 years. Stage 3A is around 14 to 33 months, 3B is 10 to 16 months, and stage 4 constitutes around 6 to 8 months. Thank you.